Hello, my name is Josie Wiles. I am a grad student at the University of South Florida. Today we will be discussing a brief overview of the role of vitamin D in a healthy physiological system, as well as health effects of sufficient or insufficient vitamin D. In this presentation, we will begin with an introduction. We will then discuss the digestion, absorption, metabolism, transport, storage, and excretion of vitamin D. A literature review was conducted of 3 subgroups: application to practice and important things to note as an RD to B, and a summary to wrap up the presentation. Rickets is a childhood disease characterized by improper bone development, and it played a role in the discovery of vitamin D in the early 20th century. D.E. McCollum is credited in 1922 with the vitamin's discovery after finding a compound that had a curative action on rickets. Vitamin D associated with skeletal growth and strong bones is also known as calciferol. It comes in 2 forms: vitamin D2, or ergocalciferol, and D3, cholecalciferol. The objective of this paper is to explain the role of vitamin D in the body and discuss groups at risk for deficiency and health risks that may accompany certain circumstances. 3 groups that are explored further in this review include athletes, those who use heavy amounts of sunscreen, and older individuals. An overview of physiological mechanisms, a review of literature, discussion, and application to practice will all be discussed in detail. We will now discuss the digestion, absorption, metabolism, function, transport, storage, and excretion of vitamin D. Vitamin D can be acquired through food sources or through sun exposure. However, very few foods in the standard American diet provide sufficient vitamin D or vitamin D at all. For this reason, foods such as milk, yogurt, cheese, butter, margarine, as well as some orange juices, breads, and breakfast cereals may be fortified with the vitamin. Vitamin D is naturally occurring mainly in fatty fish such as cod, swordfish, salmon, sardines, tuna, and herring. Dietary vitamin D requires no digestion and is absorbed from a micelle saturated within dietary fat that is absorbed with the assistance of bile by passive diffusion into the intestinal cell. Only about 50% of already limited dietary vitamin D is absorbed, and it is mainly absorbed in the jejunum. Absence of a jejunum due to previous surgical removal or the presence of conditions associated with fat malabsorption both decrease the intestinal absorption of vitamin D. The other source of vitamin D is absorbed through the skin with exposure to UV rays. When you spend time outdoors in direct sun exposure, ultraviolet B, or UVB protons, penetrate the epidermis and dermis, allowing 5,7 cholestyrenyl, or 7-dehydrocholesterol, in the plasma membrane of the skin cells to absorb the photons, which cause ring B to open, forming pre-vitamin D3. The process of thermal isomerization rearranges the unstable double bonds of the pre-vitamin D3 to form cholecalciferol. This production of the vitamin through the absorption of UVB is affected by time of day, seasons, latitude, altitude, cloud cover, air pollution, skin pigmentation, age, and yes, even sunscreen use. Individuals with a higher melanin content require a longer exposure time to generate the vitamin than individuals with lighter skin color, since melanin blocks some UVB rays. This use of sunscreen and the potential for deficiency is discussed later. Vitamin D from sun exposure, food, and supplementation is biologically inactive. It must undergo 2 hydroxylation reactions to be activated in the body. The first reaction is when the liver converts vitamin D to 25-hydroxyvitamin D, or 25-OHD, or calcidiol. The second reaction occurs mainly in the kidney when the calcidiol is converted to calcitriol, or 1,25 dihydroxyvitamin D, 1,25-OH2D. Vitamin D has an abundance of roles within the body, including reduction of inflammation, as well as modulation of some of the few processes such as modulation of cell growth, neuromuscular and immune function, and glucose metabolism. Genes encoding proteins that regulate cell proliferation, differentiation, and apoptosis are in part modulated by vitamin D. There are vitamin D receptors on many different tissues within the body, and some can even convert 25-OHD to 1,25-OH2D. Additionally, vitamin D and calcium are closely regulated. Dietary vitamin D is delivered to the liver via chylomicrons. These remnants are then taken into the liver via endocytosis. In contrast, vitamin D that is made in the skin is picked up for transport by the blood by a vitamin D binding protein, or DBP. These compounds that must be hydroxylated by cytochrome P450 hydroxylases to begin the generation of active compound. With usual intake, most vitamin D is converted to 25-OH vitamin D, but it is possible to store some in the body's adipose tissue to be released slowly when needed. Calcium homeostasis is important for vitamin D status as well. Ultimately, low blood calcium stimulates calcitriol synthesis in the kidney, which upregulates calcium absorption in the intestine and the resorption of calcium and phosphorus from bone. Other roles of the vitamin include links to disease prevention. Low vitamin D status has been associated with increased risk for hypertension, cardiovascular disease, type 2 diabetes, certain cancers, and some autoimmune disorders, among other conditions. The end product, calcitroic acid, is excreted primarily through the bile in the feces. Approximately 30% of the end product is excreted via the urine. Inadequate consumption of vitamin D increases the risk of rickets in children and osteomalacia in adults. When bone tissue fails to become properly mineralized, soft bones and skeletal abnormalities form. This disease state is known as rickets. Severe rickets can cause failure to thrive. The disease can also cause developmental delays, hypocalcemic seizures, tetanic spasms, cardiomyopathy, and dental abnormalities. Adults and older children consuming inadequate amounts of vitamin D are at risk for osteomalacia, the word literally meaning softening of the bone. This softening occurs when there is a failure to mineralize already formed bone. Similarly to rickets, bone deformities and pain, hypocalcemic seizures, tetanic spasms, and dental abnormalities can occur. A few subgroups have been identified as having special implications when it comes to vitamin D recommendations. This review of literature will discuss the effect of vitamin D supplementation on muscle strength in athletes, optimal sunscreen uses to allow vitamin D synthesis without sunburn, and the association between calcium and vitamin D supplementation and the health of older adults. Secondary biological actions of vitamin D metabolites include regulation of over 1,000 different genes in the human body. This makes up 5% of the entire protein encoding genome. A deficiency has been associated in the past with impaired muscle action and potential sarcopenia, as well as decreased muscle strength, muscle myopathy, symptoms of muscle weakness, muscle fiber atrophy, and reduction in motor unit potentials were reversed when serum 25-OHD levels were normalized. Mitogen-activated protein kinase signaling pathways in muscles may be regulated by vitamin D. An in vivo study in rats suggested that vitamin D may reduce exercise-induced apoptosis in muscle through the activation of MAPKs. Treating severe deficiency in humans resulted in improved cardiac muscle function and improved mitochondrial oxidative capacity in the skeletal muscle. This supports the idea that vitamin D may be able to improve the cardiovascular system's ability to transport oxygenated blood and the receiving tissue's ability to use that oxygen. The systematic review involving the effect of vitamin D supplementation on muscle strength had some shortcomings, including inconsistency with how included studies measured strength. There also seemed to be no gold standard among researchers on the optimal level of 25-OHD health. No conclusive results were achieved involving vitamin D2's impact on muscle strength. However, vitamin D3 may lead to improvements on muscle function parameters. So what does this mean for us? If you are considering sports dietetics, the article may be a good article to read in detail. This article calls for coaches, sports dietitians, trainers, and medical staff to monitor athletes' serum levels of vitamin D, especially during the winter months. General findings from the research recommend a serum concentration above 40 nanograms per milliliter. An optimal muscle performance. Routine testing for adequacy should be introduced into sports teams' programs. If serum levels fall below 20 nanograms per milliliter, start a supplement at a sufficient dosage of at least 2,000 international units per day for 8 to 12 weeks or until levels are normalized. The next subgroup was people who use a lot of sunscreen. Upwards of 80 to 90% of our vitamin D levels come from sun-controlled cutaneous production of the vitamin. However, sun exposure also increases risk for skin cancer. The British Journal of Dermatology published a literature review analyzing the effect of sunscreen on vitamin D levels. The sunlight contains both UVA and UVB radiation. UVB is both the cause for sunburn and skin cancer and the form of radiation that generates cutaneous production of vitamin D3. In experimental studies included in the article, 2 studies found that whole body application of sunscreen almost completely did away with the increase of vitamin D3 that was seen after exposure without sunscreen application. Studies included found that the 25-OHD concentrations increased when sunscreen was applied, but the increase was noticeably less than when no sunscreen was applied. Experimental studies indicated that with decreasing thickness of sunscreen application, there were exponential increases in 25-OHD concentration between baseline and 3 days after the final of 4 exposures. While these experimental studies, completed with artificial UV rays, did pose theoretical risk, observational studies in the same review found no significant correlation between regular daily sunscreen use and cutaneous vitamin D exposure. The article linked below provides recommendations for sunscreen use. When used properly, sunscreen is able to prevent sunburn and still allow vitamin D synthesis. Since UVB rays are primarily responsible for initiating cutaneous vitamin D synthesis, using a sunscreen with a higher UVA protection factor may allow for greater amounts of vitamin D synthesis. A sunscreen with a higher UVA protection factor, by default, allows more UVB transmission, which enables better 25-OHD3 synthesis than a sunscreen low in UVA protection factor and high in UVB protection factor. When used as directed, sunscreens with a high sun protection factor probably have a limited impact on vitamin D synthesis. However, studies report no real conclusions, as more experimental studies would need to be done to understand realistic application. What does this mean for us? Again, it is less likely to experience a toxicity from skin synthesis of vitamin D. It is very possible to experience toxicity from the use of dietary supplements. Reassure patients that long days in the sun are safe with proper sunscreen use. Before making recommendations about sunscreen use to future patients and client, it is also important that both the risk and benefit of sun exposure be considered. Reassuring parents that observational studies have shown no implications of regular sunscreen use on vitamin D status is something we can do based on this research. Encouraging kids and adults to get outside in the first place is more important than worrying about which kind of sunscreen they are using. If patients and clients still want recommendations after that, the research reviewed above did indicate that using a sunscreen higher in UVA protection factor than UVB protection factor will allow for higher concentration of serum vitamin D. Results suggested that risk of vitamin D deficiency due to sunscreen use is low and unlikely to outweigh the benefits of sunscreen for cancer prevention. The last subgroup was older adults. Up to 75% less vitamin D3 may be produced in the skin of older adults compared to younger adults due to the diminished 7-dehydrocholesterol content in the skin. The RDA also increases for older adults over the age of 70, with the decreased ability to synthesize vitamin D from the sun and an increased need for the nutrient. A supplement may be necessary for older patients and clients. So what does this mean for us? Older adults are at an increased need for the vitamin due to the decreased ability to cutaneously synthesize the compound and an increased nutrient need for the vitamin with age. It is important to conduct a nutrition assessment before recommending a supplement. Making sure older individuals are properly educated on their calcium and vitamin D needs may be a large part of our clinical practice going forward. A supplement may be needed in this population. Always staying up to date on research and not making false claims is important to the overall nutrition status of older adults. The following are all important findings of today's research. The importance of vitamin D for bone health, cell growth, and development has been previously established in prior modules. Understanding the overall mechanisms of action of the physiology of vitamin D is important to properly educate others on the special circumstances involved with intake, absorption, metabolism, storage, function, and excretion of the nutrient. One thing I learned while writing this paper is that vitamin D toxicity will not occur from the serum 25-OHD cutaneously synthesized. This means that even if you are concerned about sunscreen decreasing the amount that you synthesize during sun exposure, you can reassure future patients and clients that they can always just spend more time outdoors with no fear of toxicity. Additionally, those with a darker skin tone need more sun exposure than those with a lighter complexion. This is just another aspect of the already well-established principle that nutrition care is not a blanket that covers everyone, and care must be individualized with each new case. Always remain culturally sensitive when sharing this information with future patients. Vitamin D is an essential micronutrient. While a few subgroups of individuals were discussed specifically within this review, all individuals need to hit recommended intake levels to ensure strong bones and healthy growth and development. Understanding the intake of vitamin D through both food and cutaneous synthesis from the sun are both important when doing a nutrition assessment and counseling future patients. Continuous experimental and controlled research is needed to keep understanding new roles and benefits of the vitamin. We now know that vitamin D is important in both rickets and osteomalacia prevention, but we have only known about the vitamin for a century. As future nutrition professionals, we must stay up to date on research that could help us counsel athletes, individuals who use sunscreen, and older individuals, and any other subgroups not discussed in this review. Here are the resources used in this presentation. Thank you.